So the kidney is an organ that filters blood to make urine. And the parenchyma, or meat of the kidney, is made up of tiny filters that filter the blood to get rid of excess toxins and fluid. The urine is first collected in the collecting system of the kidney and then goes down the ureter to the bladder, where we store urine until it's appropriate to urinate. We can see lesions of in the meat of the kidney, or parenchyma of the kidney, what we call renal cell carcinoma. The other type of kidney lesion we can see is urothelial carcinoma of the kidney. That's a rarer disease, but it is from the collecting system itself. And the two are treated in different ways. The renal cell carcinoma, which is usually found incidentally, is best treated by surgical removal, by removing just that portion of the kidney with the mass and sewing the rest of the kidney back together to continue to function. Urothelial carcinoma, the disease of the lining of the collecting system of the kidney, can be more difficult to treat. Often we'll need to remove both the kidney and the ureter in its entirety, although we are seeing some local therapy now available, including mitomycin, which is a chemotherapeutic that can be placed into the kidney and take care of some smaller lesions. The majority of renal masses and renal lesions are found incidentally on imaging that patients have for other reasons. Many times we'll find what's called a renal cyst. A renal cyst is a fluid collection, almost like a bubble of fluid on the kidney. We see kidney cysts very often. Up to 50% of men and women of the age 50 have a renal cyst. We can have cysts on our kidney, on our liver, on our pancreas, on our ovaries. Cysts are not necessarily dangerous, and when they're found to be thin-walled fluid collections, we know from the imaging that those are universally benign and do not need further imaging or treatment. If we see what we call a complex cyst, where the fluid in the cyst is not necessarily clear, or if we see some thickening of the wall of the cyst, there may be the need for further imaging to follow that. If we see something that shows solid components to it, then that's more concerning for a renal malignancy that would need to be treated. There's a radiologic score we call a Bosniak score that looks at these images and rates these renal lesions based on a Bosniak 1 would be a simple cyst, thin-walled fluid, not dangerous, benign, and does not even need observation, can be ignored. Bosniak 2 may be a little change in the component of the fluid that needs to be watched. Bosniak 3 would be more solid components or thickening of the wall of the cyst. And Bosniak 4 is a solid lesion that is much more likely to be malignancy. Bosniak 3 and 4 lesions need to be treated. Bosniak 2 can be followed often, and Bosniak 1 can just be observed. When we find a lesion on the kidney, one of the questions we get sometimes is, why not do a biopsy of that renal lesion? And the reason is because the biopsies are not reliable. They can tell us that there is disease there, but they can't tell us their disease is not there. And so when we see a suspicious lesion, there is some small risk of putting a needle into the kidney, some small risk of bleeding, a very rare risk of spreading disease. But if we see the biopsy is positive, that can tell us the disease is there. But if the biopsy is negative, that cannot tell us disease is not there. I tell my patients to think about an apple with a rotten spot. We might stick a needle in the apple and get back good apple. That doesn't mean you want to eat that apple. Sometimes the needle will go in and show scar or necrosis or even normal kidney tissue, but it doesn't mean that there's not cancer there. The majority of kidney cancers these days are found incidentally. When a patient has imaging, a CT scan or ultrasound for another reason, a mass can be found on the kidney. The majority of these masses are these days found small enough and isolated to the kidney that they can be treated very effectively with a very high chance of cure. For many patients, the best approach is what we call a partial nephrectomy. That is where we remove just the portion of the kidney that has cancer in it, using a thin rim of normal kidney to make sure that we get all of the disease. This is best approached robotically. We can do that with small 1 centimeter incisions to put in the camera and the instruments. We're able to remove the mass, sew the rest of the kidney back together so that it can continue to function. That can be approached in multi-port robotic surgery, or these days we now have a single port approach, which uses a smaller robotic incision where recovery is seen to be even quicker.